This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of pre-sport care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today on the podcast, we're looking at fatigue. So it's true to say that fatigue is something every clinician working in emergency care understands. So the long shifts, the nights, the unpredictable workload, the pressure of making critical decisions when you know your cognitive reserves are being challenged. Yet despite fatigue being one of the most recognised human factor risks in safety critical industries, it remains one of the areas where healthcare often struggles to move from awareness to action. So the reality is that fatigue is not simply about feeling tired. It's about how sleep loss, circadian disruption, workload and recovery impact the very things that make us safe clinicians. So fatigue affects decision-making, communication, situation awareness, teamwork, and the ability to recognise risk. So in aviation, rail, and other safety-critical industries, fatigue is managed through structured systems designed to understand and reduce risk. So in healthcare, we're increasingly recognising that asking individuals to simply cope better is not enough. So fatigue is a systems issue and it requires a system response. So in this episode, we bring together two important perspectives that explore this challenge from different angles. So first we hear from Professor Christy Sanderson and the CatNaps research program, which is examining how comprehensive fatigue risk management systems, or FRMS, could be developed and implemented within the NHS ambulance service. So this work asks some really important questions around what fatigue interventions are actually supported by evidence, also how we can make them practical for frontline teams, and also how we can organise and create environments where fatigue is recognised, reported and managed as a safety issue. Then we move to more of an international evidence base with Professor Daniel Patterson from the University of Pittsburgh. Daniel has led some of the most influential research examining fatigue in emergency medical services. So he's helped develop evidence-based recommendations around shift length, fatigue mitigation strategies, workload and systems design. So ultimately, fatigue is not just about how tired we feel at the end of a shift. It really is about whether we're creating systems that allow clinicians to perform safely, support each other effectively, and provide the best possible care for patients. So this episode really explores the science of fatigue, human performance, and building safer pre-hospital teams and fundamentally systems. Okay, we'll see you next week on Monday for the next release. Please feel free to rate, review, and indeed subscribe to the podcast, and we'll catch you again soon.
Some new studies that have come out sort of since the pandemic, and the international literature looking at paramedics and emergency services, we can see that sort of anywhere between like 2/3 to 3/4 of staff will be experiencing significant fatigue on shift. So those numbers are quite shocking, but they're also consistent with the levels of fatigue we see in other health settings, like in emergency departments, for example. And if we kind of think about the immediate effects of fatigue, they do include things like difficulties concentrating, you might have difficulties with your memory, trouble finding the right word. So I think we can all quickly see how that could cause problems for clinicians. I think an interesting one as well is that fatigue can also be associated with impairment of emotion regulation. So people may not be as calm as they usually are under pressure. Perhaps they may not be quite as skillful at diffusing challenging situations. So all of these things together, I think we can all readily appreciate how they might kind of impact on a clinician's ability to deliver the care at the level they want to. And of course, an obvious one for ambulance services as well as road traffic accidents, which are very well known risk from fatigue. both from inattention but also extreme drowsiness, which could also include like micro sleeps, for example, so nodding off at the wheel. Of the sorts of things we can expect to see in terms of sort of heightened risks. So there's evidence that fatigued paramedics can be twice as likely to be injured on shift, and they're about 1.5 times more likely to report a medical error. So things like you've mentioned about whether it's a sort of incorrect clinical decision or medication error or whatever it might be. Um, Obviously, kind of as we mentioned, we also know that where ambulance staff are required to drive at high speed, it may be on rural and remote roads, and also that staff are required to make often very complex clinical decisions in what might be an unpredictable physical environment. So we can see if you're having trouble with your memory, having trouble with your concentration, having trouble with your emotional regulation, trying to make all of these complex clinical decisions in unfamiliar physical environments, I think we can appreciate how this might start a chain of actions that can lead to compromised staff and patient safety. Because we're interested, of course, in our sort of ultimate goal of improving patient safety. But for me, staff are front and center of this as well, because one of the best ways to improve patient safety is to improve staff outcomes and safety as well. But the goal of CatNaps is to help the NHS ambulance sector develop a fatigue risk management system. So an FRMS is simply a collection of recommended, ideally evidence-based actions that address what we call the root causes of fatigue and poor sleep, and importantly, that are considered feasible and acceptable by staff. So we're going to develop this fatigue risk management system. We're going to develop some implementation guidance so ambulance services can tailor to their own setting and circumstances. We're going to produce a prioritised list of outcomes so that they can track the impact of any changes that they might make over the coming years. So the way we're doing that is we've had kind of a long lead-in time of compiling all of the evidence about what might work in the ambulance sector. So we're thinking really, really broadly here, which I'll give a couple of examples in a minute. But we basically wanted to have a look across any sector, any industry, what scientific evidence or practice-based evidence is there that could help us understand what might work in the ambulance sector, so we can take that to staff and stakeholders and get them to tell us whether they think it will work or not. And we have a sort of a particular sort of implementation science framework that we're using to sort of help us unpack that evidence. Then we're doing some kind of detailed qualitative work with frontline staff and patients to really sort of understand on the ground how is fatigue experienced, what sort of facilities or physical areas do staff have if they're lucky enough to get a break? Do they have somewhere where they can have a quiet rest? Are they allowed to nap? This is something that we've discovered is hugely controversial. Some stations are quite positive towards staff if they're having a break to have a short sort of timed nap. Other staff are reporting that where they work, it's essentially a sackable offence if they're caught napping on shift. So this is a really interesting one for us because this is an evidence-based strategy that is recommended for fatigue risk management, but we can clearly see within the NHS and in particular in the NHS ambulance sector, there's huge diversity in how this kind of particular strategy is approached. So we're going to use our sort of detailed work to unpack some of that. And then we're pulling it all together to develop our sort of implementation guidance, which is effectively a tool to help services prioritize what they want to change, how they want to change it, how they'll bring staff with them, and what sort of outcomes they'll be tracking going forward. We're taking a systems or a public health approach that looks across all aspects of a person's life and working life that may be contributing to disrupted sleep or fatigue or to both. And importantly, considering what might be modifiable. So, when I say sort of like a public health approach, the sorts of risk factors fatigue we've been looking at include health conditions. So there's the obvious ones like if somebody has an actual sleep disorder, but we're also looking across mental health and physical health conditions that are known to disrupt sleep. So that could be chronic pain, it could be menopause, it could be post-traumatic stress disorder, it could be depression, alcohol misuse. We, of course, are looking at aspects of working life, so shift patterns, shift duration, whether people get breaks, what sort of alertness actions people kind of take on shift, work intensity, job stresses. But there's also a lot of things that people can kind of have control over themselves. So their sleep habits. Do they drink close to when they go to bed? Are they doing heavy exercise just before they try and sleep? These are things that we can look at to understand our staff getting the right advice around what sorts of things they could change. And of course, there's a range of, I guess I'd call contextual information that we need to take into account here. So people live in different sorts of housing environments, different members of their household. They might live in a really large, noisy household. They might live in a really quiet household. They might have certain sort of personal or cultural practices that we need to take into consideration when we're thinking about how can we help staff sleep better. So we're thinking really holistically. So when we think about risk stratification, for me, it's how we break down those risks and looking at what are our options for tackling some of those risks. So it probably helps to kind of give you the framework that we've grouped our sort of potential strategies we could include in an FRMS. So we've got two main types of approaches. So fatigue reduction, that's preventing fatigue and sort of reducing our root causes. And then we've got fatigue proofing. So that's where we're looking to minimize the consequences of fatigue for staff and patients. Because even if we did everything right, we provided all the best kind of sleep education, if we made sure everyone was getting help for their mental or physical health conditions, if we had the best designed shifts in the world, there could still be people that might turn up on shift fatigued or develop fatigue on shift. So we need to have ways to keep people safe while they're working. So when we look at fatigue reduction, so this is our prevention, the big one here is design of working hours. But we also look at education and training around sleep and sleep patterns. We look at specific interventions for health and well-being, and we also look at what managers can be doing in this space in terms of very high-level support, like having a fatigue risk management policy. At the moment, we know that only one of the 13 standalone ambulance trusts in the UK actually has a fatigue risk management policy, so that's probably a really good place to start. But then there's all the complexity of things we can do while on shift. We could use technology to identify when somebody is nodding off while driving. This could be a camera-based system in the cab, for example. We're aware that some of the ambulance companies are actually future-proofing their ambulances by having spaces for cameras. If the sector chooses to sort of adopt this technology in sort of who knows 5 or 10 years time. But there's all those things that clinicians and staff just do instinctively on shift when they're tired to try and stay awake. They will drink caffeine if they're allowed to, or they might have a sneaky nap. They might use other sort of substances that are sort of known to be a stimulant. They might do behavioural actions like moving around, listening to music. Humour's a big one, kind of keeping each other going by sort of talking and joking around a bit when you can. So all of these things are focused on the type and level of risk. And we hope that what we've done through this evidence review is offering the sector a broad range of actions that they could take, some of which that they'll already be doing, but a lot which they haven't had the headspace to think of yet. So we sort of see it as our job, as pulling all that evidence together for them, getting them to tell us why they think something will work or not, and then helping unpack what they think would be different if they choose to adopt some of these approaches.
And it's great in a way that it's coming, or the posture is that it's kind of coming from them in a way that, because I think there's probably more adoption and ownership when the recommendations are built in collaboration with the ambulance services. So I can see this hopefully going to be really a lot of collective agreement with the ambulance services. But could you maybe speak to the archetypal 12-hour shift, really? Because services internationally institute 24-hour shifts, and these might not be as busy as, say, central London or other places within the UK. But I certainly know from anecdotal experience of the peaks and troughs of fatigue, and the anecdotal evidence that you're 30% more cognitive fatigue at the end of a 12-hour night shift. You've got the equivalent of 2 to 3 units of alcohol on board because your responses are so delayed. Could you maybe speak to what the research shows around the peaks and troughs and or the cognitive fatigue on a 12-hour shift?
Yeah, I think the first point I'll make is just to acknowledge that many staff like the 12-hour shift for both personal and financial reasons, and that they're not yet ready to move on from it. That being said, the evidence really is accumulating that 12-hour shifts are not really ideal for anyone. Some people do adapt to working 12-hour shifts, even if they've kind of have a run of a couple of day shifts and then move to a couple of sort of 12-hour night shifts. But many people do not ever adapt, and they're a real struggle throughout their career. I think what's useful to think about the 12-hour shift is really how and when it's risky, because if we acknowledge that while the evidence says 10-hour shifts are better, 8-hour shifts might be the best, we have to acknowledge that probably for some time we're still going to be working with the 12-hour shift model. And I think you'll probably recognise, Owen, and many of your listeners will, about the sort of danger zone around that sort of 3 to 6 a.m. period when you really feel that building pressure, the sleep pressure or urge to sleep that can happen at that time. You can feel cold, you can get the shakes. Some people report feeling really sick in their stomach, like quite nauseous, and sleepy and drowsy at the same time. So you can understand in terms of sort of a physiological state to be, it's not very pleasant. And some people really experience this quite strongly. So we need to think about what we're asking people to do in those particular sort of high risk times. And there have been kind of suggestions about how we might sort of modify tasks for those particularly risky time periods within a 12-hour shift. But we always kind of come back to sort of the pragmatic approach of this study, in that there's the evidence sitting here with all these kind of ideal things about what might be done. And then there's the reality of the huge demands on the sector at the moment that are the highest they have ever been. So we have to be realistic about what we can actually change, and understand that we'll do what we can to support people when they're in risky hours. But in terms of, complete redesign of shifts and patterns of work, we would say are likely a longer term goal.
So, Christy, from your perspective, how do we, what other ways do we experience fatigue? So, I'm used to doing sort of a run of, say, 4 night shifts or 4 day shifts. And on that fourth night shift, you're right, the sleep pressure or just the chronic fatigue of not really sleeping well over 3 days has not only impinged on my decision making, but my mood, my patience, my ability to de-escalate other people, and indeed be coherent. Um, could you maybe speak to the incremental fatigue that sort of builds up over the aggregation of 12-hour days or night shifts?
Yeah, absolutely. I think it's a really important point, and the concept I like in the literature to sort of think around this is the idea of intershift recovery, because it's kind of exactly describing what you're talking about. So as you're working those run of nights, whether it's two, three, four, you will build up a sleep debt, because when you come off your night shift, you will get a bit of sleep, but it's not going to be usually your preferred duration or the quality of sleep that you would like, because you may be coming home trying to sleep in a noisy household, or you want to spend time with your friends or family before you go and get some rest. So that will have a cumulative effect in terms of building up this sort of prolonged sort of sleep debt of basically the difference between the number of hours you should have been asleep and the number of hours you've kind of actually been asleep, and that is different for each person. And one thing we're kind of really interested in, I think, helping individuals and ambulance services think about is not just thinking about the individual, but thinking about their family as well. Because somebody who's done a run of nights, who's chronically fatigued, who's kind of right in the middle of a period of sleep debt, they may not be themselves. They might be a bit short tempered. They might be a little bit cranky. They might just be too tired really to engage in kind of any of the things they might normally do in their sort of normal home life. So I think we could do a much better job supporting families and friends of shift workers, whether it's NHS ambulance or kind of any other sort of shift work in sort of high demand kind of healthcare settings. So I think we've got a piece of work to do around how we bring families with us, because they are often sort of the recipients of the consequences of this sort of extended fatigue.
So, Christy, could you unpack the change in logical model that's associated with the study and sort of how it might look like in reality on the back of the catnaps study?
Yeah, so one of the goals of the study is to try and map out quite a high level, what we call sort of logic model of the suite of options that trust could do. So, like the inputs, the immediate changes we might see, and then kind of the longer term outputs and outcomes that we might see from these changes. So, as part of our consultative work we're doing at the moment, so this is through workshops, through a survey, through staff interviews, we're asking for feedback on how we might sequence the actions that end up in a fatigue risk management system. So, what needs to be in place first? Are there any early wins? What might be longer term actions? So, an example is a fatigue risk management policy. We might say it would be ideal to have that in place first, but actually, we know from one of our ambulance services, the one that has gone down the path of developing it, it has taken them some years to do it. So, we might say that's really important to sort of show that high level organisational buy in, but there's a lot of things we could be doing while those sort of longer term strategic work is done. But that bit of work will help give us a sense, I guess, of any ordering of inputs that might be required. Then we'll map across to what changes we might see in the short term for staff. So this could be the things we've sort of talked about, like improved concentration, reduced risk for incidents or accidents. We would hope over time to see improved staff retention, improved staff well-being. We might see things like a reduction in sickness absence, with all of these ultimately leading to safer patient care and a positive patient experience. So obviously this is a very complex causal map we're talking about here, which is why it necessarily will be quite high level. But I think it's a really useful way of capturing all of the information that staff and patients will be telling us about what they'd like to see done differently and how they think it might make a difference either to delivery of care or to experience of care.
In EMS and pre-hospital care, we don't really have any evidence-based guidance for operational issues. And one of the most glaring issues operationally in pre-hospital medicine and in medicine in general is shift work. And we've had this wealth of new evidence that has come into our view in the past 2 decades regarding sleep, health, and fatigue. And many of those studies, whether they be experimental or observational, have focused on healthcare workers in particular. And so when you have that body of evidence available for synthesis, it makes sense to try to look at the best available evidence and to see what we can glean from that to inform our practice, in particular our operations regarding how we care for our patients. And so the evolution of that stems not only from the obvious, which I just mentioned, was we have this evidence, we should look at it, we should synthesize it, what does it tell us? But also we've had numerous safety events that have been linked back to sleep, poor sleep, fatigue in medicine in general, but also in pre-hospital care. So the stimulus, if you will, is a combination of we've got evidence available, let's look at it. And two, we've had these poor safety events that have obviously been linked to sleep and fatigue. And so we need to look at this. And I think globally, when you're talking about EMS or pre-hospital care globally, we all share some characteristics. We might operationally deploy differently, and I'll talk about that. But globally, we don't know when we're needed. The volume of work is unpredictable, right? And you can go from a very simple patient interaction where you have to basically do a lift assist. Grandma fell down, you got to pick her up, put her back in her chair. There's a refusal. There's no stress. It's pretty straightforward. And you can immediately go to something very severe and acute, like a pediatric cardiac arrest or a traumatic event, a multi-car collision, something like that, and the stress level is elevated. Well, you go through that over a 12, 24-hour period, you can imagine how fatiguing and exhausting that is. That is a very unique work environment. And then on top of that, you add how different EMS operations deploy, like in the US, where we are dominated by 24-hour shifts. we are now seeing a rise in the use of 48-hour shifts and longer. You add the long-term exposure of that chaos, that unpredictability, and it seems pretty straightforward that yes, we're going to have folks who are stressed out, burned out, exhausted. So it's inevitable that people who work in this industry become very, very fatigued. And then one of the PICO questions where we actually found extremely limited evidence, but was a very hot topic, is use of something called biomathematical models. These are algorithms that have been developed to sort of help predict when fatigue might be high and when alertness might be high or low or vice versa. These biomathematical models are used every single day to sketch out how pilots and co-pilots staff their shifts. Well, because these models are so widely used, especially in aviation, one would think, wow, there must be a body of evidence that supports the widespread use of this unique tool, right? Come to find out, when we actually did the systematic review on that, there was very little evidence. So the origin of the questions that we addressed were driven by what are the possibilities of finding a body of evidence on these questions, what are important questions to our industry, and what are novel, what are hot topics that we need to try to address in this, knowing that we can't address all questions. Yeah, so we knew going into this, because EMS in general is a younger profession compared to other professions such as transportation, military, nursing, other healthcare workers, aviation, shipping, rail, other high-risk industries. We knew going into this that if we were to isolate our search of the evidence to just those studies that focused on pre-hospital care regarding sleep and fatigue, we would find some evidence, but probably not a lot, right? Well, other shift workers who do rotating shifts, night shifts, long duration shifts, they exist, and their body of evidence might be more expansive than if we were to just isolate it to EMS. So we actually included research of pilots, military, transportation, shipping, rail, other high-risk industries, nursing, physicians, because we knew that the body of evidence would be dominated by those professions. And while it's not direct evidence, we talk in terms of direct and indirect evidence. Direct evidence being evidence of your population of interest, specifically the workers who you are interested in this case, paramedics, EMTs, pre-hospital nurses, for example. We know that evidence is somewhat limited at the current time. And so if we can glean anything from the evidence of other populations, that's of some use, right? I mean, it may not be direct evidence, but it's still indirect evidence and is of some use, because we all undergo the insult of shift work. We all undergo the challenges and exhaustion of shift work. So what they go through, we are most likely to go through something similar. So it's worth looking at that evidence. So we spent a lot of time capturing and scanning the literature of not only EMS related literature, but also of non-EMS related literature. To find, again, the whole purpose is to find the best available evidence.
So just looking at, so we are going to address some of these hot topics actually, Daniel, because I think to your point, it's prudent to maybe review these from an evidence-based medicine perspective. But let's start with shift length, the evidence versus culture. Could I get you to really maybe unpack for us the evidence around shorter versus longer shifts? Because it is quite emotionally charged within EMS. So, what did the systematic reviews actually show? And indeed, where does belief still outpace the data?
So, I mean, I think we all know the answer to this. The longer that you work on duty, especially beyond 12 to 16 hours, that's human physiology. You're going to get tired, right? Especially if you're doing overnight shifts, when it's normal for us to have a lot of sleep pressure and want to sleep. Our bodies are built, humans are built to sleep at night and be awake during the day. If you try to go against that, you are obviously going to suffer some level of fatigue, some level of sleepiness and exhaustion. And so it is a hot topic. It is controversial. In the US, public safety is dominated by longer duration shifts. And there are reasons for that. One of the reasons is staffing. Most operations, whether they be EMS or fire or rescue in general, they don't have the resources to employ a lot of individuals. So they rely on fewer staff to cover the 24/7 need. And in doing so, that means any one employee is going to work longer, typically longer shifts, 12s, 16s, 24s, or longer, because there's just not enough resources available to pay for adequate staffing to staff, regular 8-hour shifts or 12-hour shifts. If you shorten your shifts, you need more people to work them. And in public safety in general in the US just doesn't have the funding, the hard funding to support that. That's number one. Number two, it's been tradition, right? It's just something that the way we've always done it, right? And actually convincing the old guard, the folks who are more senior in the professions that provide EMS and rescue, et cetera, to convince a lot of them that we should change is a hard thing. This is the way we've always done it. The newcomers should do the same thing, et cetera, et cetera. Another reason is the employees. You'd be surprised. A lot of the employees, despite the exhaustion, despite the fatigue, despite what it does to them, many of them actually prefer the longer shifts for a couple reasons. One, I can get all my work done in a few days and spend more time with my family if I work one job. Two, many people in EMS actually between 30 and 50% across the US actually work more than one job in order to make a standard of living that fits their needs. So in order for them to work multiple jobs, they're going to work longer shifts at one place so they can go and work another set of shifts at a different place, right? Because the income that they make is just not sufficient to maintain a lifestyle that they are seeking. So those are two dominant reasons. One being this is tradition, right? And two being it's an attractive model for the employees because it fits their lifestyle, despite the threats to their safety, despite the threats to their health, et cetera. Well, caffeine is the most widely used drug in the world.
Yeah.
Number one, okay. Greater than 85% of healthcare workers consume caffeinated beverages during work. Greater than 85%. Some consume a fair amount, consume more than 400 milligrams per shift. Okay, now if you think about that, if you think about your standard grande or medium-sized coffee from Starbucks, that can range between 200 and 300 milligrams. So just imagine someone drinking a Starbucks or more medium to large coffee over the course of a shift. That doesn't seem like a lot because most of the drinks that we have available to us today are actually very highly caffeinated. And so number one, people drink it all the time. There's a lot of healthcare workers who drink caffeine. Strategically using caffeine, obviously, are the answer to questions like how should you use it? That's a complex thing to address. There are some from the sleep lab at Harvard, for example, who recommend what they call microdosing, where you basically have 200 or so milligram coffee, and you just microdose yourself every hour to maintain alertness over the course of a shift if you are required to maintain wakefulness. Simply slamming a coffee where you're taking in 200 milligrams in one dose in a very short time period can lead to these ups and downs in alertness because the caffeine metabolizes in approximately 30 minutes and the half life is around 5 to 6 hours. So you're going to have these ups and downs with respect to your level of alertness, right? The issue with caffeine availability, that's the focus of that recommendation. It's not that we recommend you consume caffeine, but because it's generally safe, it's widely used, that the employers, the recommendation specifically says, employers, please provide access to caffeine. You would be surprised. Many rescue organizations, EMS, fire, for example, they may provide the resources to allow consumption of caffeine, like, for example, the coffee maker, but they don't actually supply the caffeine. The coffee grounds, for example, they require the employees to supply it for themselves. You might think intuitively that, wow, that seems like a simple thing that an employer could do. We have one organization in our Western Pennsylvania area that has over 18, I think 18 base sites across multiple states. Guess what their budget is to supply coffee across those 18 base sites?
Yeah, go
It's a
on,
lot.
go on. It's a lot,
30
yeah.
over $30,000.
Wow.
Okay. It's not cheap. So what you might assume is an easy strategies that should be widely used, widely adopted, is actually, it comes at a cost. So the recommendation was, look, it's a safe drug. There's evidence to support its use to maintain alertness, especially during night shifts and long duration shifts. Just basically consider supplying it, not supplying the resources that would allow them to bring it in themselves, but alleviate some of that burden on the employee, supply the coffee, supply the caffeinated beverages, right? And then with respect to napping, yes, it is controversial. If you go to YouTube and you look for Cleveland EMS napping, there's this very widely distributed news story of a member of the public walking by and seeing a paramedic and EMT in their truck parked in the fire department parking lot, and they had just fallen asleep while sitting in the truck. And it made the news. This is probably a number of years ago, and it was basically conveyed as a very negative thing, right? And the public's perception of people sleeping on the job can be quite negative. The reality of EMS is what I mentioned earlier. You have these ups and downs in terms of stress and burnout level. Exhaustion can go really high, and then all of a sudden you have a moment to rest, and then a moment later you're back up stressed, right? That contributes to a lot of exhaustion. You add the fact that we work really long duration shifts and there's little time to rest. The need to actually have time to rest, the opportunity and the permission to rest is something that is it can be a hot topic, right? So maybe the city council member who's in charge of the EMS budget, or maybe the county council members have a certain opinion about sleeping on the job, right? And they would probably be upset if they found out that the firefighters or the paramedics or EMTs were sleeping on the job during the middle of the day, for example. Why are they sleeping on the job? It's the middle of the day, right? And so that can be a really tense conversation. However, given the demands of the job, and given the fact that most people in EMS get less than 6 hours of sleep prior to shifts, most of them have very irregular sleep schedules, and given the evidence recently that says that is bad, not only for their sleep health, but for their health in general and for their alertness, you probably want to do something regarding sleep that can help them maintain alertness and be at their best, right? The literature suggests that napping can help. It can't solve all those alertness issues or all those sleep health issues, but it can help to mitigate some of it. And so the recommendation was that you not only give EMS clinicians the permission, but the opportunity to nap. Now, when you start to ask, okay, how long should the nap be? When should it be applied, et cetera? Those are complicated questions that require a whole separate podcast. But in general, the best available evidence would suggest that a napping strategy can help to mitigate some of the insult that we are exposed to with respect to exhaustion during shift work. The vast majority of negative safety outcomes in the US regarding EMS have been transportation related, where the driver, the EMT, or the paramedic in an early morning transport fell asleep at the wheel, ran through the intersection, was hit by another car, or ran off the road, hit a tree, for example. And there have been deaths. There have been deaths of paramedics in those situations. There have been deaths of patients in those situations. But yes, you are absolutely correct that when you're in the moment with a critically ill patient, it's pretty clear that most EMS clinicians will maintain alertness and do everything they can to care adequately and optimally for that patient because you have that stimulus, right? But when you're in the monotony of behind the wheel in a very early morning hour of a transport or a long transport, that monotony is basically nighty night. It's lights out. It's time to go to sleep. And it's really hard to withstand that pressure. So you're absolutely right that the biggest risk is transportation with respect to how sleep can affect our performance.
Let's look at education and fatigue training and education, Daniel, if possible. And education is often seen as a soft intervention, but how strong was the evidence, to your mind, that the fatigue education actually changes the outcome, like safety, like sleep quality, or indeed like burnout?
Thanks for asking that. And yeah, you would think that that's a soft intervention, as you just described it, right? And it kind of is. It's something that actually is immediately available to a lot of organizations, especially if they are able to contract with or consult with academic institutions that provide education free of charge, or the hospital system, which often has continuing education programs related to these topics. These are quote unquote easy to get at, quite easy to implement interventions, especially if you don't want to do it in-house, if you want to rely on organizations or individuals with expertise in this outside. The best available evidence where they have different studies have tested sleep health education programs with similar types of shift workers, healthcare workers, transportation workers, etc., is overwhelmingly positive. Overwhelmingly positive for outcomes like sleep quality, which is an important outcome. And so we actually tested this ourselves. We actually, in the papers published in the Journal of Sleep Health, and it got published, I think it was in 2023, the EMS Sleep Health Study is a cluster randomized trial where we actually tested an education program, a very simple 10 modules, very short duration program, where basically EMTs and paramedics were asked just to view some educational materials on the importance of sleep health, different aspects of sleep health, sleep physiology, sleep diseases, interventions that can help mitigate fatigue, etc. If you just present this information to the target population, we have shown that it actually has an impact, a positive impact on fatigue, for example. So it is a soft intervention, but it is extremely effective.
Yeah, absolutely. No, absolutely. Let's pivot slightly and look at biomathematical fatigue models. I guess in a way, for many clinicians, it might sound quite abstract, but if I could get you to really maybe just unpack and speak to, what good implementation looks like, and indeed, what when calibration alone isn't enough, could I get you to really speak to, just the relevance of a biomathematical fatigue model, and maybe how it gets us to more robust, informative sort of data.
Yeah. So there are a number of investigators across the country who have developed different biomathematical models. And a lot of these models are currently in use with very large organizations like aviation companies, Delta, American Airlines, international airline companies. They all use these biomathematical models as part of a comprehensive fatigue mitigation scheduling program. So that's not the only thing they rely on, but it's woven into the fabric of a program that looks at all different kinds of factors, but it's a very dominant component. And what goes into these biomathematical models? Number one, what are they? They're basically algorithms. Essentially, they're just algorithms. Well, what goes into the algorithm is data that comes from humans. So they basically collect data on normal physiology about sleep patterns, wake patterns, that can include data from shift workers and non-shift workers to essentially look at where are the risks, where are the time points in a day, in a 24-hour period, where the risks are greatest, right? If they get data from shift workers, they'll look at a pattern of work, they'll look at a pattern of sleep, they'll look at a pattern of alertness, and they'll incorporate that data into the models, which can help calibrate the models and help to determine how can we optimally schedule pilots and co-pilots, for example, so that we mitigate these elevations in fatigue, elevations in poor sleep and sleepiness, and maximize their rest, so that if we schedule someone on a long duration flight, for example, that we know going into that they're going to be optimally prepared, have adequate rest prior to taking that responsibility. So those models are used in that regard. Like if they're scheduling these long duration flights, for even short duration flights, how many flights have the crew members been on prior to this one schedule? Can we bring in additional crew members, for example, at a certain time point? It helps them to make decisions. It doesn't actually dictate who is assigned to a particular leg or a flight. It just helps the people who are in charge of making the schedules, it helps them to make decisions. We don't have a lot of data out there on this. That is a really surprising thing. And one of the reasons these biomathematical models are proprietary, right? So as soon as the people who developed them proved that they were legitimate, that they were reliable, that they were valid, they marketed them. right? And they were able to get companies to buy the rights to use of these models. That limits how much research is publicly available. Okay, so that's one reason why you don't see a whole lot of research out there on this, is that they're proprietary. But we do know, because of how widely used they are, that they have to be effective. I mean, if some of the world's leading aviation companies and other high risk industries are using these models every day, then that would tell you something. They're probably effective. We just don't have any data from EMS clinicians or related professions that could help say, wow, in this particular type of work environment, this type of occupation, it's effective. We just don't have data on that. Yeah. Ask your crew members, what are they doing right now to take care of themselves in terms of their sleep health, on duty and off duty? And maybe what you do is you just codify what some of the things that are actually going on now behind the scenes without official approval, because those work for the individuals, right? So it could be a variation of a napping policy. So for example, I used to work in an agency many years ago where we didn't have a base. We actually had to stay in the ambulance the entire shift, right? And so having a place to nap meant either getting outside the ambulance and getting on the ground, or you get in the back of the truck, or you do it in the seat. Well, in that situation, that can be a challenge, right? And in that organization in particular, it was actually against policy to nap. You were not allowed to nap. So in that kind of situation, my first recommendation for agencies who deploy like that is think twice. Like, I mean, kind of go back to the situation. There's evidence to support this. Be creative. As long as one crew member is awake, for example, and ready to operate the ambulance and to respond, maybe give permission and the opportunity for the second crew member to take a quick 20-minute, 30-minute snooze, just to kind of alleviate that sleep pressure. If you're worried about the public's perception, have them get out of the passenger seat and get in the back of the ambulance out of view. That's a creative way, right? It wouldn't cost you anything. You don't have to build any new facilities to do that, right? And also in that kind of deployment model where they don't have a base site, if you are positioning these crew members, for example, on a street corner in the middle of the night, and there's no convenience store where they can walk in and get a cup of coffee or some other energy drink, for example, and you're trying to figure out how to adopt the caffeine recommendation, I know a lot of employers will supply Gatorade, water in that kind of situation. Why not also consider some caffeinated beverages, right? Why not also consider that? That way, if they do get positioned in a street corner where there's no access and they didn't bring the caffeine themselves, they had access to it. At least they had access to it. That's a creative way to implement that recommendation, for example. And the soft recommendations that are more feasible for most organizations who are definitely apprehensive or are concerned about cost, for example, education and training. There are numerous sleep medicine physicians and clinicians out there, whether they be PhD or MDs, who know a lot about sleep physiology and who know a lot about the literature. Work with them. They are more than willing to do free education programs. They can record it on Zoom and send you the video. Maybe you do it as a formal Con Ed lecture. There are numerous opportunities here for that kind of strategy. So I would say education training is really a low-hanging fruit. Work on that. Yeah.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.